So we call upon our next speaker, Dr. Manisha Agarwal. She'll be talking on comparing combination therapy versus systemic therapy for managing ocular tubercular granulomas.
A very good afternoon to all of you. (138). A very good afternoon to all of you. So tubercular granulomas is the most well-recognized phenotype of intraocular tuberculosis. These are hypoxic granulomas with very high VEGF levels, leading to abnormal vasculature around these granulomas and leading to an unequal distribution of the ATT drugs, thereby reducing it to a monotherapy and causing the risk of multi-drug resistant TB. The hypoxia also makes the MTB bacilli dormant, and INH in the ATT is unable to act on the dormant bacilli. We have published our initial work where we found that the VEGF-A levels in these granulomas was 5 times higher than that found in a CNVM, and a prompt clinical regression was found in all the cases on giving treatment with anti-VEGF along with moxifloxacin. And this is the role where we give anti-VEGF, which decreases hypoxia. It avoids the bacilli from becoming dormant, because of which the INH becomes more active, and it also normalizes the vasculature, thereby decreasing the risk of multi-drug resistant TB. However, the limitations of our previous study was that it was a non-randomized study and the sample size was small as 10 patients, and there were certain questions which remain unanswered. How do these granulomas behave on a long-term basis? What are the recurrences? And how does the healing differ when we treat them only with the systemic therapy versus a combination therapy? So the aim and objective of this study was to compare the anatomical and visual outcomes between intervention group, which was the combination plus systemic therapy, versus the control group where only the systemic therapy was used, and also to compare the recurrences between the two groups. It was a randomized prospective study, and all the consecutive patients of intraocular TB granulomas from January 22 to September 23 were enrolled in this study. The intervention group included an intravitreal injection of bevacizumab along with moxifloxacin, which was given every week till the granuloma regressed, along with the systemic therapy. And we also analyzed the aqueous samples for the VEGF levels. This is one of the case examples from this study, which is a 16-year-old young female patient who had bilateral TB granulomas, and you see a large granuloma in the right eye, which was enrolled in the intervention group, and the left eye was put only on the systemic therapy. This is the timeline of the right eye, which was treated with 4 intravitreal injections of moxifloxacin along with Avastin, and you see the high VEGF levels which were touching 2000 picograms per ml. There was a beautiful regression of the granuloma in the right eye, and the patient recovered a vision of 618 N8 after 4 injections along with systemic ATT and steroids. In comparison, the left eye, you see that there is a regression of the granuloma even in the left eye without the intravitreal injections, but the difference, if you notice, is very subtle. You have extensive RPE atrophy, which you can well appreciate in the macular area, and the scarring of the granuloma is very high in comparison to the other intervention group. We did face recurrences in the right eye, and where you see there are 3 recurrences which were seen at 12 weeks, 36 weeks, and 68 weeks. But they were all the reactivation of the CNVM, which we picked up on OCTA, and not the reactivation of the granuloma. So we had 26 eyes of 23 patients. The mean age was around 25. 24 eyes had choroidal granulomas. 2 eyes had optic nerve head granuloma. 7 patients out of 23 had an evidence of active systemic TB, and 3 patients had a history of ATT in the past. There were decreasing levels of VEGF levels, which correlated well with the clinical regression of the TB granulomas. The minimum follow-up was around 24 weeks, and the average size of the granuloma was 4 disc diameter. However, the recurrence rate was quite comparable in both the groups. And if I was to highlight the difference between the two groups, the time of regression of the granuloma was around 4 weeks in the combination versus 11 weeks in the control group. The healing showed less scarring in the combination group versus more scarring in the control group. The visual outcomes were better in combination because of more scarring. The vision either decreased or stabilized. The recurrences were comparable in both the groups, and the flattening of the granuloma took more than a year in both the groups, and it was really not dependable on what therapy we used. So to conclude, a combination of intravitreal injections, that is anti-VEGF, moxifloxacin, and systemic therapy, offers an advantage over systemic therapy of ATT and steroids alone in both anatomical and visual outcomes. The recurrence of fluid is primarily because of the reactivation of the RAP or the CNVM lesions and not the granuloma. The number of recurrences are very much comparable between the two groups. Thank you so much for your patient listening.
I think it's a very good initiative which you have taken. Just one or two questions. You have put intravitreal moxifloxacin also, which also has an ATT effect.
Absolutely.
So you think it was the anti-VEGF or the moxifloxacin which did the trick?
So, ma'am, in our first paper that we have published, we have described that both anti-VEGF and moxifloxacin have their own different roles to play. The anti-VEGF basically acts on the abnormal vasculature that's developing around the granuloma, so that the penetration of the ATT drugs is much more to the center of the granuloma. As far as the moxifloxacin is concerned, it is acting on the macrophages which are surrounding the granuloma, which are harboring the MTB bacilli. So it is basically going to be pushing out the MTB bacilli and killing them.
So you think if only moxifloxacin is given,
it won't act. It won't act. It won't.
Are there any studies on that?
Yes, there are studies, and the reason being because macrophages are in turn surrounded by the abnormal vasculature. So till you don't get rid of that abnormal vasculature, the drug is not going to be reaching the macrophages.
One more question. Your diagnosis of tuberculous granuloma, like you said, only 7 patients had active tuberculosis.
Systemic TB.
Systemic TB.
Yes.
So did you do a PCR for the AC tab to confirm?
Very few patients. I think out of the...
How did you make a diagnosis of tuberculosis?
Ma'am, we have like, it is...
Clinical.
It's a...
Clinical.
The phenotype is so typical of a TB granuloma.
So clinical, it was a clinical
Yes, it was a
diagnosis.
clinical.
Right.
Just one question. I wanted to know, you are giving these injections every week.
Yes.
Every week? Or
Yes,
Yeah.
every week.
So,
So-
what would happen if I spaced them a bit more? And
So in our initial experience, when we used to treat them like once a month, it used to be a very slow
Yeah.
response. And we lost those eyes. They became painful blind eyes with extensive neovascularization of the iris. Now, because we've done a VEGF analysis and we know what high levels of VEGF we are dealing with, and also because these are inflamed eyes, you have a breakdown of the blood-retinal barrier, so the washout of the drug is much faster. So once a month is too low a dose. And now, from the time we have started treating them once a week, the granulomas regress beautifully, and we have never had a complication that the eye have become an absolute eye.
so it's between once a month and once a week.
Yes,
It's-
absolutely.
So you've just taken it as once a week. And another question is, would you think any other anti-VEGF?
Absolutely. I mean, you can use
No,
any...
I'm just saying that from the point of view, you could use anyone, but then would it reduce the time that is required? Because you are also a retina specialist. If
I
you
would
if you
totally agree
use-
with that, Dr. Mayur. That's a very keen observation. Since these patients were non-affording and Avastin, we
Yeah.
can give free, so we opted for Avastin. I'm sure other anti-VEGFs will also have a role to play. And if you have a longer durability of the anti-VEGF, probably yes, it can increase the increase the frequency or decrease the frequency of the injections. But I'm not too sure with the high load, like I showed, it's 2,000 versus a CNVM which has only 250 picograms per ml of VEGF, whether that's really going to be able to compensate.
Having said that, if you went that way, you would lose the advantage of having the weekly moxifloxacin.
Absolutely. I agree.
And
I
also the VEGF you calculated was the serum in the
No,
plasma?
ma'am, it was from the AC tap.
So you did AC tap every 2-3 times to see how much the
Not
VEGF was?
really. Otherwise, whenever we gave the intravitreal injection, we took an AC tap sample and then subjected it to an ELISA to get the VEGF
So you
levels.
have the ELISA in your
Yes, we do
institution
have.
for
Yes.
VEGF.
Yes.
Thank you.
Thank you so much.